Good afternoon, everyone. We're so happy to have you join us today for Lameness Conditions Affecting Performance of Path International Horses with Dr. Ashley Phelps-Dunn. Dr. Ashley Phelps-Dunn is chair of the Path International Equine Welfare Committee and brings her knowledge as a practicing veterinarian to help Path International members improve their skills in determining lameness and distress in equines. We're so happy to have you here today, Ashley. Welcome.
Thank you, Rachel. I'm very happy to be here. So without further ado, let's go ahead and dig into the meat. So first of all, one of the things I'd like to point out is AAEP, which is the American Association of Equine Practitioners, has guidelines for equine retirement and rescue facilities. And a lot of times our PATH facilities double as rescue or retirement facilities. So I'd like to point out this very thing. Equine veterinarians play a huge role in the care of these animals at our rescue and retirement facilities. We can offer valuable advice on many aspects of equine management, from disease prevention to basic nutrition, from emergency medical attention to routine health maintenance procedures. It's very important that facilities establish good relationships with an equine veterinarian for the benefit of all, especially for the benefit of horses. And I challenge you to look at your relationship with your equine veterinarian. And is it as strong or as good as it should be? And if not, see why and talk to your veterinarian. So we're going to discuss some of the common conditions that we see in some of our PATH horses. First, we're going to start with laminitis, also known as founder. And then we're going to discuss navicular syndrome, osteoarthritis. We're going to look at a conformation issue called clubfoot. And then we're going to look at some of the neurological lameness, mainly focusing on EPM today. So the hoof is incredibly important. Actually, in gallop, do you know the horse actually puts 2 times its weight on 1 foot? The average foot's about 5 inches in diameter. So that's on average about 2,000 pounds on 5 inches. So that's pretty remarkable. And it goes to show how important the hoof is. That old adage, no foot, no horse, it's incredibly true. The hoof actually is responsible for supporting the weight, absorbing shock. It resists wear and provides traction to the horse. It's important to help pump blood. It conducts moisture, and if anybody's ever been kicked, you know it's a part of defense. Some estimate that actually 90% of lameness is involved in the foot. So it's no wonder a lot of things we're talking about today involve the foot. So laminitis, or also known as founder, actually occurs from a disruption in the blood flow from the insensitive and sensitive lamina. So those insensitive and sensitive lamina connect the coffin bone, which is the bone that sits in the hoof, and the hoof wall together. And as those start to die, the bone can shift. Now, laminitis can be chronic in nature. It can be short-term. It can be intermittent. Severe cases can actually result in separation from the bone and the hoof wall. So that's where you'll get rotation and or sinking of the bone. So if you look in the image at the top, that's normal. So you can see the hoof wall and the coffin bone are pretty tight together, and they're parallel. But in the image on the bottom, you can see that the coffin bone is actually dropped in that image. So we really don't know why this happens. We know there's a disruption of blood flow. We know certain things can actually precipitate it, but we don't know the exact mechanism of how it happens. We do know that laminitis affects the feet, but it reflects a disturbance elsewhere in the horse's body. So here are some of the known causes of laminitis. So we have digestive upsets such as grain overload. So when the horse breaks into the feed room and eats all the grain, that's why we worry. Abrupt dietary change, sudden access to less pasture, severe colic or severe diarrhea. And a lot of times when they become ill, they'll actually release toxins within the horse's body. And this can happen like in high fever or routine placenta. And that can cause laminitis, even though we're not really sure why. Excessive concussion on the feet, aka road founder. Excessive weight bearing on one leg due to an injury. Remember Barbaro? He had a fracture, didn't he? But actually what ended up getting him is he could not continue to support all of his weight on one leg, and that actual leg foundered. primary foot disease, bedding from black walnut shavings, so always know where your shavings come from. We do know that high doses of corticosteroids is suggested to cause laminitis, but it's actually not been proven. But we always use it very carefully in these animals. So when we're talking about risk factors, breed's really important. So we know a lot of the heavier breeds are prone to laminitis, as well as ponies and miniatures, and donkeys as well. And we know that if they have an endocrine or metabolic imbalance, that they're more likely to founder, so like in cushingoid horses or horses that have insulin insufficiency. So what does a horse look like? Well, that classic sawhorse stance where their feet are pushed out in front of them. Okay, sometimes they're mostly lame on their front feet, but it can be in all four. Sometimes you'll just notice it when they turn, or they'll have this kind of walking on eggshells appearance. If you feel the feet, a lot of times you can feel heat in those feet. You can see an increased digital pulse. So there's actually an artery that runs across the back of the fetlock, and that pulse is very hard to feel. But if you feel it really easily, you know you've got some inflammation going on down in that foot. A lot of these horses will shift weight from one leg to the other. Much like us, if both of our feet hurt, we tend to shift our weight. Horses will do the same thing. And when a veterinarian comes out, we actually apply hoof testers and pinch the toe. And a lot of times those guys are very sensitive, but I've had some that are so severe I can actually just press with my thumb and they will flinch. And sometimes you'll see the dished hooves. In this video here, you will see a horse that's actually foundered on all 4 feet, and her front feet are actually tucked back and her back feet are a little bit more forward. Kind of looks like she's standing a little bit on a ball. So sometimes you'll see that when they founder on all 4. This is actually a very improved version of her. When I first saw her, she would not get up. So it's diagnosed by your veterinarian. They'll come out and do a lameness exam. They'll look at the feet. They'll apply the pinchers or hoof testers. And they'll look for heat. They'll look for pain. They'll also want to take some x-rays or some radiographs. And that will actually tell us what is going on inside that hoof. So as you can see in the image over here, this is actually an x-ray of a horse that's foundered. And what the veterinarian has done is they placed the hoof on a block. They taped here it looks like a hoof nail on the very front of it. And then you can see there's actually a little bitty, it's not a tack, but it kind of looks like that on the bottom. So that way they can see where the bottom of the sole is and where the edge of the hoof is. And ideally that nail and the edge of the coffin bone there, which is the bone that sits in the hoof, should be parallel. And as you can see, it's actually not. So from the top of the coffin bone, there's less space between it and the nail than at the bottom where there's more space. Sometimes we'll do a venogram. I haven't done one of those too often, but we know there's a disruption in blood flow. So if we have some chronic cases or we're very concerned about blood flow, what we'll actually do is inject dye into the blood system of the horse, and we'll take a series of images, and that'll give us an idea of where the blood is going. And then in certain situations, we can actually do an MRI as well. So as far as management, you want to consult your veterinarian, but oftentimes veterinary recommendations will include modifying the diet, particularly if they have a metabolic imbalance. So a lot of times that looks like a low starch or a low sugar diet. And we almost always restrict them from pasture. We know the sugar content, particularly in the morning in the pasture, can be very high. And if these animals have a metabolic imbalance, we really don't want to give them a bunch of candy, which is basically what lush pasture is. A lot of times we will recommend hoof supplements. And one of the mainstays is routine hoof care. It's really great for us to know, since that bone can move around in the actual hoof wall, what has happened. So that's why radiographs or x-rays are very important. And they're also important to help your farrier determine how to trim that foot. We'll put them on some pain medications. A lot of times you'll see some phenylbutazone or Bute or Equiox. And we want to make sure these guys long-term are in good health maintenance protocol. We want to make sure their vaccines and deworming are all current, because if they have a metabolic condition, they can be prone to other illnesses. Now, as you can see here, this is one of the shoes that sometimes I recommend. It's actually called a Scott Morrison shoe. As you can see, it's a little thicker in the back and thinner up top, and it has what's called a rolled edge. A lot of these guys, what I like to do is take some toe back and kind of roll it so it makes it easier to pick it up. And then I'll have them do this roller motion shoe and apply putty or something soft like Equipack actually across the heels, because we know if we apply very mild heel pressure that actually their sole can grow much faster. But we don't want to put anything over the toe because that's where it hurts, right? Because that toe is moving a lot of times. So what we'll do is we'll kind of leave that open. It's kind of like you don't want to, if you have a blister, you don't want to wear shoes that put pressure on the blister. Same kind of principle there. So as far as prognosis, it really depends on the severity of the condition. And I'll be honest with you, I've seen horses that have had terrible x-rays do very well. And then I've seen some horses that don't really have too terrible x-rays not do well. And a lot of it has to do on their pain level and their response to therapy. I find that even some of the more severe conditions, if they respond very quickly and we can manage their pain level and keep them comfortable, they do very well. You also have to look at those underlying conditions. So if you're not treating those cushion-oyed horses or not providing their correcting their underlying issue as best as possible, you're unfortunately not going to be successful. As far as work recommendations, typically I do not recommend they return to work until they are sound, meaning not lame, preferably without pain medication. I do have some that stay on some low-grade pain medication, but it really depends case by case. Typically, it requires strict management, but a lot of these guys do return to work, but it does depend on the severity of the condition. So this guy down here, he is my horse. He found her, when he was 12, and he lived to be 38, and he only had one episode because we managed him so well. So as far as navicular syndrome, it's a very dreaded word in our industry. But what it is, it's a group of related conditions that affect the navicular bone and structures in the foot. So if you look at the image, you can see the navicular bone, and then just underneath it is the bursa that's created by the DDFT, which is the deep digital flexor tendon. And then you'll see at the very edge of the navicular bone what's called an empire ligament. Any of those structures, plus two more that I'm going to show you on the next slide, can cause symptoms of navicular syndrome. So there's several possible causes for pain in that area. So now some have started terming this caudal heel pain syndrome. So you can also see, now there's a lot of ligaments on this particular picture, but I wanted to point out the suspensory ligament of the navicular bone. So there's two other ligaments that attach to the wings of the navicular bone called suspensory ligaments, and they hold the navicular bone in place, and sometimes those can be injured as well. And then the the picture on the right actually shows what a navicular bone looks like, and you can see this one actually has some damage because you can see that mottled appearance, whereas it really should be smooth. And what we know is as the digital flexor tendon rubs across that, it can cause that bone to change, and it can give you this mottled appearance. But that's only one of the potential causes of caudal heel pain syndrome. Typically, when we see a horse that we think may be suffering from caudal heel pain syndrome, they're usually bilaterally lame, meaning they're lame in both front feet. But some of the early signs, we can see some of these horses that trip, or maybe they'll just have a short, choppy stride, or sometimes they'll have a history of intermittent lameness. So they'll be lame for a couple days, maybe after a hard particular ride. You rest them for a few days, they seem to do okay for a little bit, then they go lame again, never too terribly bad. Maybe you don't call the veterinarian, and then you rest them for a few days and they seem to get a little bit better. It's typically an insidious onset, and a lot of times we can see the lameness a little bit better in the turns or when we lunge them. When a veterinarian comes out, one of the things that we see is they're sore across the heels when we apply hoof testers or hoof pinchers. And when we're dealing with caudal heel pain syndrome, there's a couple things that have to be there for us to kind of say that that's what's going on. First of all, they have to be lame, okay? And they have to be bilaterally lame. The lameness must improve with what's called a palmar digital nerve block, or interarticular coffin joint anesthesia. So what that means is there is a nerve that runs right across the back of the heel bulbs there. Sometimes you'll see veterinarians take a little needle and they'll put a little lidocaine or some anesthetic in there to kind of numb it. And if that horse goes sound or feels much better after that, we know the pain is coming from that area, okay? After that, typically we recommend taking x-rays. Now, the x-rays are only going to show the bony parts. So we'll see the navicular bone, okay? We'll see the coffin bone, but we may not see, actually we do not see the soft tissues. So just because we don't find anything on the x-ray doesn't mean there's not something going on. It could be early, or it could be soft tissue. So like that impar ligament, the deep digital flexor tendon, the suspensory ligament of the navicular bones. You need MRI to rule out those soft tissue lesions, particularly in chronic situations that don't respond to treatment. So as far as treatment, you need to consult your veterinarian. And a lot of the recommendations that you will see, one of the standards is definitely corrective shoeing. Now, sometimes you can do corrective trimming and not the shoeing, but it is a case-by-case basis. So a lot of times what we're trying to do is correct the mechanical or physiological imbalance. Some of these horses have underrun heels, or they'll have medial, which is toward the inside of the leg, to lateral, which is on the outside imbalance. So sometimes they're just crooked. Sometimes they'll have shallow soles. And a lot of times what we'll do is we'll put them on NSAIDs. So these are pain relievers. This would be like your fetal bunazone or your Equiox. Sometimes we'll actually inject the coffin joint because we know that that can actually diffuse into the navicular area, or we can actually inject that navicular bursa directly. Sometimes we'll put them on supportive medications like asoxaprin. On the very rare occasion, surgery may be recommended. And what they do in surgery is typically they take out part of that nerve so the horse doesn't actually feel its feet. Now, I just want to stress to you that this is typically end-stage chronic cases for salvage. We very rarely recommend this because I don't know about you, but I don't want to be around a horse that can't feel its feet. And then one of the newer medications that has come out quite recently are the bisphosphonates, which are Tildren and Osphos. And what they do is they reduce the bone absorption that has across that navicular bone. So if you're dealing with a navicular situation where it's just the bone, these medications can actually slow down that bone breakdown and actually slow the overall disease process. But they will not help if you have a soft tissue issue. So with proper management, many horses can return to work. Prognosis will depend on the structures that are involved, but unfortunately, the degree of pathology or the degree of changes that we see on the radiographs doesn't always correlate with the pain. So I could have a horse that has terrible x-rays, but he's completely sound. And then I could have horses that don't have any changes on x-ray and they could be very, very lame. So unfortunately, I don't have a crystal ball a lot of times when I'm dealing with this syndrome, which makes it so challenging and frustrating for our path horses. But with proper management, a lot of these guys can continue work. Sometimes you may have to back down their work level. So if they were, perhaps maybe they were doing some jumping or some high level work, you may bring them down to a walk trot or a walk trot canter horse. In the image here, you can see A is actually more of a normal navicular bone. B, you can start seeing some mottled changes in the middle there. You can see those dark areas. C is a little bit worse. And D is where you see that core lesion, almost looks like a thumb a lot of times. So they can really, really be in any area there if it's bony conditions. So osteoarthritis. Osteoarthritis is defined as a disease of the joint that results in progressive degradation and destruction of the cartilage of the joint. So let's picture two ends of bone, and I'm going to put a sponge in the middle. Now, as those bones keep coming together, the sponge is going to wear out and get thinner and thinner and not be squishier and not be squishier. That's actually kind of what cartilage does. It's kind of like the sponge. Osteoarthritis can occur at any age, and it's really due to a multitude of factors. And reports show that even as much as 60% of lameness cases are due to some level of osteoarthritis. Just like in humans, there's no cure. There's only some management options. So some of the signs that you see, particularly early on, is you'll see some subtle changes in the way the horse moves. Maybe you'll have a shortened stride. Maybe you'll have hollowing the back. Maybe they don't want to take the bit as much. You'll see a raising of the head. Sometimes they'll be stiff before warming up. Or what you'll also see is maybe just as they're coming out of the stall, you'll see them kind of be a little stiff, but as you move them, they get looser and looser. Other things that you'll see is you'll see maybe they want to swap a lead or not pick up a certain lead. Bottom line is they'll be unwilling to perform a task that came easy in the past. Occasionally you'll see some puffiness around the joint. So as you can see in this picture, it's a picture of a knee. You can see how swollen it is compared to the other one. Occasionally you can see warmth, or if you manipulate that area. So like in this horse, when I moved the knee, when I picked up the foot and moved the knee back and forth, the horse was a little painful. And of course you'll see signs of, you'll see some lameness. For diagnosis, you do need a vet exam. So what they'll do is they'll do a lameness exam, which usually involves trotting the horse on different surfaces, maybe lunging the horse, probably doing some flexions. So we'll hold up part of the leg for a period of time, then ask them to jog off. Sometimes we can do even some nerve blocks where we'll numb certain areas. Once we figure out the area we think the horse is in pain, we'll take x-rays of it. And depending on how severe the x-rays show, how severe the osteoarthritis is on the x-rays, depends on what we do next. On rare occasions, we'll do an MRI. And then occasionally you'll do some arthroscopy. So what that actually is we have a little bitty camera device, actually the surgeons do, that they can actually slide into certain joints and look around and look at the cartilage. You'll usually see that performed on young horses or horses that have had an injury. So the management, first, of course, consult your veterinarian. I think I've said that on every slide almost. But we want to manage the pain. Okay, so we may give them some non-steroidal anti-inflammatories. So that's like your bute, your Equiox, your Banamine. And a lot of times we will inject corticosteroids actually into the joint. And a lot of times we mix those with hyaluronic acid or polysulfated glycosaminoglycans. We can also inject intramuscularly the polysulfated glycosaminoglycans. So you don't know what that is, guys? That's Equine. Okay. And then sometimes we can give an IV version of the hyaluronic acid, and that's Legend. Weight management is important too. I'm sure you know with people, if you have a bad knee or if you've had a hip replacement, they want to make sure that you manage your weight, because the more weight you put on your joints, the more difficult it's going to be for the joint to handle that. You can do some non-weight bearing exercises like swimming or physical therapy. And a lot of times we'll modify the diet by maybe adding some more omega-3 fatty acids, or of course doing some oral joint supplements. So conformation faults can lead to pain, usually due to arthritis, and can impede performance. So one of the things that's kind of in that boat is club foot. It often requires additional management, but a lot of these horses can do very well with proper management. So when you're dealing with a club foot, they're more upright. And what actually happens is this is actually where one of your flexor tendons, if you're a horse, is contracting and pulling up that coffin bone. A lot of times you will see this in young horses, and if you catch it when they're very young, like 3 to 6 months, you can actually have more effect. But after they're about 1 to 2 years of age, really what you can't change that, but you can hopefully help manage it. Okay, so you can see the different classes of this. My own personal horse, she is a grade 2 and she's done very well. Routine hoof care is very important for these guys. If you do not have a farrier that is comfortable working with corrective trimming or shoeing, you need to find one. The first place to call is your veterinarian, because most of the time we know who can do the corrective trimming and shoeing. If not, you can go to the American Farriers Association and click Find a Farrier. Now with clubfoot, there's no real cure, but you can manage these guys usually quite well. So neurological lameness, we're going to shift gears. We've been talking about the foot a lot, but we're going to talk about something else now. So neurological means it affects the nervous system of the horse. That's the brain, the spinal cord, and the peripheral nerves. Depending on what area is affected, depends on the signs that you see. So sometimes it can just affect body awareness. So right now, if you're sitting or standing, you know where your body is, you know where your feet are. If you've ever had a condition where you maybe have had a spinal condition and all of a sudden you can't feel your feet, that's kind of what happens with these horses. Sometimes they're painful, sometimes they're not. And actually you can see in this picture, this is me with one of my most severe cases to date. And you can see his body's going one way, but his legs are going the other. This guy was highly, highly unstable. EPM is actually one of the more common conditions, equine protozoal myeloencephalitis, that can cause neurologic symptoms. It is the master of disguise. I've seen it look like almost anything. The primary cause is the protozoal parasite Sarcocystis neurona. There's no vaccine. There was a vaccine on the market several years ago, about the time West Nile came out, but it was not proven effective enough to stay on the market. So let me show you a video of a horse that's had EPM. So you can see him doing a tail pull here. He's very weak. I should not be able to move him over, and I move him over very easily. You can actually see his general body condition. He doesn't look like he has a lot of muscling. This horse is actually a high-level eventing horse. He should not look like this. This is not from lack of care. This is from the illness. And if you also notice, he kind of shifts his head to one side as well. So one of the common signs that you see is incoordination and weakness. A lot of times it'll worsen if they're going up and down slopes or if the head is elevated. You'll see muscle atrophy, so that's kind of like what you saw in the horse in that last video. He just didn't have a lot of muscling. Well, he had it. It went away very quickly and usually can go away in a few days. It's usually most notable along the top line or the large muscles of the hindquarters. Sometimes you can see it in the face. I have seen a horse with facial paralysis, so his lip was just drooping and so was his eye on one side. You can see, and I saw his mouth drooping too. He actually couldn't swallow either, and his ears were kind of offside. So you can see that. Some of them will have difficulty swallowing. I have seen that. Some of them will just start sweating. They'll have a loss of sensation sometimes around the face, the neck, or the body. In severe conditions, they can actually have a head tilt. So their head will be tilted one way. Some of the horses will have kind of a splay-footed stance, or they'll be leaning up against a wall. One of the craziest cases I ever saw was the horse was just shivering. It was July. He responded quite well, though. So here is another video. This guy can only circle one way. I had to guide him the other way. You can notice I'm standing very far away from him. Okay, he's circling very slowly. Notice his head's tilted one way, and notice he's actually chewing. But as you get closer, and notice I'm very careful with where he is, you will see he actually has a little bit of that nose twitching a bit. And unfortunately, he could not eat or swallow. We had to tube in for that. And he would have almost like these focal seizures across his nose here. Yeah, and the reason I was making this video is because I was sending him to a referral. But you can see how his nose keeps twitching back and forth. Yeah, so a very interesting case. Unfortunately, diagnosis, there's no specific test. A lot of times we rely on the physical exam. So we want to know vaccine history. We want to make sure that these horses have been vaccinated for West Nile, rabies, and of course, rhino. We want to look at some blood work. Sometimes they will get some CSF fluid. So that's the fluid, the cerebral spinal fluid. A lot of times we'll do a tap. Typically, I don't do too many of these. I usually rely on response to treatment. You can also do some blood work where you pull what's called titers, so we can look at antibodies. In my neck of the woods, almost all of them have been exposed. So I actually get more worried when I see a negative titer than a positive titer, because what a titer means is just the horse has been exposed to EPM itself. EPM here in the South is very ubiquitous. So usually I rely on responsive treatment for diagnosis. There are some drugs that are specifically labeled by the FDA to treat them. You want to consult your vet to see which one is best for you. The one I use the most is Marquis or Panazaril. It's an oral paste administered for 28 days. Another one that I've used is Rebalance. It's also an oral suspension that you administered once daily for 120 days. And then there is a pelleted alfalfa-based top dressing for feed, diclazerol, that you can apply there for 28 days. The other things I do during treatment is I typically give them some anti-inflammatory medications. So your NSAID, that's your Benuine, your Bute, your Equiox. Occasionally in severe situations, I will give them corticosteroids. I usually recommend they're supplemented with vitamin E, which is an antioxidant that does seem to help healing of the nervous system. So I'll actually, if they can eat, I would recommend supplementation there. And then, of course, supportive therapy. So if they can't eat, I'm going to tube them. If they can't drink, I'm going to give them fluids. Those are the more the severe cases. And then I'm also going to tell people to be very careful around them, because depending on how severe they are, as you can see, those horses, I don't want really anybody to be around until they're better. Success rates for this are actually pretty high. Now, not all horses respond to therapy, but typically I get a significant response in the first week. And I will say approximately 10 to 20% of horses may actually relapse. Typically, if they do, you're going to see that in the first month to 6 weeks after stopping treatment. 70% of my horses with my treatment return to normal 100%. I would say 25% will improve, but may have some residual deficit, and depending on that deficit, they may or may not be useful at their current job. And then I'll lose about 5%. The 5% that I lose are typically already down at presentation, or they continue to relapse. I've had a handful of those. So when they're undergoing treatment, you really should monitor for signs of improvement or decline. And then, of course, you do need to watch for negative side effects, just as like diarrhea, or if they're on NSAIDs, like some stomach ulcers or things of that nature. And it's really important to report any changes in the horse's condition to your veterinarian. So in summary, work with your veterinarian on a detailed, individualized plan for your equine partners. So that way you can set realistic goals and you know what to look for. And with that, Rachel, can you let them know how they can ask questions?
Certainly, Ashley, and thank you so much for such thorough information for our members working in the field. If you have any questions on the information in this presentation or how you can further support your program horses, let us hear them. Please email the Pathern National Office at pathnintl@pathintl.org, or join professionals on the Pathern National Equine Managers Facebook page. And thank you for taking the time to learn more about this important topic, and thank you, Dr. Phelps.